Thanks so much, Alison. Lovely to hear your presentation. I haven't heard Alison speak for some years, and really great to get that update as to where the field lies. And Alison's just done amazing work over several decades. Also interesting to hear about childhood trauma. I'm an investigator on what's known as the Australian Child Maltreatment Study. If people aren't familiar with this study, it's the first national survey anywhere in the world that's measured the 5 types of child maltreatment. We interviewed 8,500 Australians to determine how prevalent physical abuse, sexual abuse, emotional abuse, neglect, and exposure to domestic violence is in the Australian population. For those of us who work clinically, we know that child maltreatment permeates all aspects of mental health. The associations we found in a study with mental disorders are just stunning and very concerning. And if we're going to make a difference in terms of preventing all forms of mental illness, we've really got to work to keep children safer. But that's not what I'm here about today. I'm here about talking about optimising treatment. I'll just start by acknowledging traditional owners of lands, the Gadigal people of the Eora Nation, paying my respects to elders past, present and emerging. I've got some disclosures of these companies have engaged me to do work with them, but they've paid my employer or given money for research at the institutions I work at. I've never received direct funding from any of them and such. So a little bit about me. I'm a child and adolescent psychiatrist. About 2010, I got asked to run the early psychosis service at Metro North. As a child and adolescent psychiatrist, I'd done a PhD in psychosis, and I thought, well, this is, I should be qualified to do this, should be pretty straightforward. In coming in to do the service, I realized actually how complex it is to look after people who are living with psychosis. The needs are complex, the stress in the family is complex, and I realized that I was woefully ill prepared for this. We built our service up over 12 years, and I think over that period of time, I think we had a good service, and I was very proud of the care we're delivering. And during that time, I saw, reflecting upon what the speaker said this morning, and I'll be giving much the same message, there's some frustrations that continued throughout that time. As I said, we know what needs to be done, but it's really hard to communicate, to get clinicians across Australia to provide the best care for people who are having their first episode of psychosis or having early psychosis. And in fact, when I look at what our early psychosis service provided, what it was, we provided a platform of excellent medical management, really assertive, kind case management, psychological care. And on top of that, we're doing some of the family interventions. We looked after physical health very assertively. We had various specialty therapies like cognitive remediation and CBT for psychosis, and we had employment support and educational support. So that was quite a collection of interventions. But not every service can do that. And certainly people who are out in their private practice or GPs and such can't do that. That requires a well-funded model. But what everyone can do, I believe, what every prescriber can do is provide excellent medication management. And that's really what I want to talk about today. And it does follow a lot about what was said in the first session. So I have some bad evidence, but what I'm going to talk a little bit more about is sort of, as a clinician, how we give a message to our people we're looking after who have a lived experience of psychosis, and to their families as well. We, with Jackie Curtis and others, we got a collection of people together to sort of outline what we thought were the key principles in doing optimal prescribing for early psychosis. We published this in Australasian Psychiatry a couple of years ago, and it lays out what we think are 6 key principles and the evidence behind them. And essentially the key principles, if everyone did this, we believe that the outcomes for consumers would be so much better. And essentially it is when people have their first episode of psychosis, people choose a medication based on the lowest side effects, okay? And I'll explain why that is. that they start metabolic monitoring right from the start. They sort of get in early with their assertive physical health care. They encourage use of long-acting injectable medications, as has been said this morning, that they identify mood disorders. A lot of people who come in with their first episode of psychosis are also experiencing depression or they're experiencing mania. Often it gets overlooked and overshadowed. There's a sort of diagnostic overshadowing with the psychosis, and people forget to treat the mood disorders. So get in and treat the mood disorders as well. Provide information and really intensive information to consumers and their families about the medication. I think this is something which psychiatrists and doctors generally do really badly. We don't sit down and spend that time explaining what we are doing, why we're prescribing these medications. These medications, a lot of them have such terrible side effects. So you really need to give a convincing rationale for the person who's receiving them as to why they should consider continuing with them. And finally, consider clozapine early and such. So I'm not going to go through all these principles in the interest of time, but I just want to touch on a few of them. And they've been explained already in part, so I'm going to do it quickly. Essentially, you've heard first episode psychosis. Generally, the majority of people get a really great response. And I saw in my 12 years of working with the early psychosis service, people would come in and they would say, they come into their first episode of psychosis, I commence their antipsychotic medication, and they get well, and I think, gee, we've done this great job, this is fantastic, and such. And as you've heard earlier this morning, people would sort of, after a time, would say, look, I want to come off the medication. Coming from a child and adolescent background where we treat a lot of ADHD, and people often say, look, I want to come off my stimulants. So, yep, that's fine. You take them off and it works or it doesn't. And so I was using that same principle with psychosis. People want to come off, sure, we'll see how that goes and such. Gee, more often than not, it went really badly. So I learned very early on that, we need people respond really well, but that doesn't mean that they'll stay well. We need to think about how we get them to stay well. Essentially, the antipsychotic medications in that first episode of illness, most people respond, 60 to 80% of people respond, and they're all of equal efficacy. I keep hearing from various psychiatrists, this person, the nature of their psychosis, their first episode, I think they need the risperidone, or I think they need the olanzapine. It's going to be too severe for the Abilify. It's going to be too severe for Reagula or something. Not true. All these antipsychotics are equally effective. So we shouldn't be thinking, this needs a olanzapine. We should be thinking, which medications can be most tolerable for the person? When we looked at a RCT we did up in Brisbane recently, and we looked at what medications were being prescribed for people with their early psychosis, the most common antipsychotic was the one that does the most metabolic harm, olanzapine. So people weren't going for the medications that were safest. They were going for the one which was sort of sedating, causing most obesity and causing most harm. And so when we're choosing antipsychotic, my message to people is choose the one which has the least side effects, because likely they're going to respond to the medication least side effects, they will to the ones with most side effects. So choose one with the least side effects, going to cause less harm. And young people, they're just not going to tolerate taking medication. It causes sedation, it causes weight gain, it causes sexual dysfunction. They're going to stop it. So choose medication which young people are going to take and keep taking and such. And so this is a vignette. I've seen, these are sort of just made up, but I've seen so many Matthews over the years. So Matthew's brought to hospital with psychosis and aggression. He's commenced on olanzapine, and after a 2-week admission, he has a good improvement. He then comes to the outpatient service where he continues to improve, but he's now gaining weight, he's fatigued, and he doesn't want to keep taking medication because he can't sort of go to university, and he's worried about his physical health. He says, and his parents say, look, I want to stop this medication. It's just causing too much harm. We don't want to keep going and such. And we sort of say, maybe switch to a different one, a safer one. But by this stage, we've lost Matthew. he's kind of well. He doesn't want to go to another one. He's saying, look, I want to be off it, sort of thing. But unfortunately, what happens is that Matthew goes off the medication. 4 weeks later, he relapses back in hospital, and the same thing happens again. So this is what happens when people start patients with having their first episode of psychosis on a medication that causes a lot of iatrogenic harm. They'll inevitably stop it, and almost certainly they'll relapse and such. So you've got to choose medications which are safe. So treatment decisions should be, there's a real key practice point. Choose a medication based on the reduction of side effects. Medication you initially prescribe is the one that you want the person to take for a long time. People aren't going to take olanzapine for a long time. People probably aren't going to take risperidone or quetiapine for a long time. They could have too many side effects. Choose the medications which have much less side effects. Decide what when a person comes in and they're aggressive and angry, because I hear this from all the time, the patient's looking after, they're so aggressive. If I don't use olanzapine, how do you manage them? Well, polypharmacy, think about psychosis, the phasic illness. In the acute phase, when people are really distressed, polypharmacy is quite okay. In fact, it's almost essential. Work out what is your primary antipsychotic and make that the antipsychotic that you want the person to be on for a prolonged period of time. Work out what adjunctive medications are needed to keep everyone safe. So your primary antipsychotic might be aripiprazole, for example, which is sort of metabolically much safer. You might need to add in some olanzapine or some lorazepam or both. And you explain this to the patient. You explain to the family what you're doing. Explain it really clearly. And then as the person gets better, you're maintaining the metabolically safe primary antipsychotic, you're withdrawing the other medications over time. It's all about communication. It's all about saying what you're doing so that people know. Such encouraging the use of long-acting injectables. I'm not going to labour this point too much. You heard this morning the sort of all the evidence for it. In summary, you do get improved adherence. Non-adherence is known. I will explain this part. More stable pharmacokinetics, and you've got time to develop a safety plan. You've seen the slide. It's a different picture, but it just demonstrates again when you sort of randomize people to long-acting injectable versus oral risperidone, much higher relapse rates than the oral medication, even in a clinical trial. And again, you've sort of seen these studies showing from Sweden that people sort of do much better when on long-acting injectables. But what I want to do is just sort of give a case vignette to highlight how we're using long-acting injectables, and I think using them really well. So Martin, he was a young man who came to see us. He'd been unwell for a long period of time. He was so unwell, he was homeless. There was domestic violence order out against him. He couldn't go back to his family and such. So he came in and we commenced him on a long-acting injectable antipsychotic. He had an excellent response. And he went back and he started to trade. He was an apprentice tradesman and doing really well, reconnected with his family, could go and visit them. The violence order was removed. A really happy outcome. Anyway, sometime later, his dad rings me and says, look, Martin wants to come off his medication. Can you speak to him and see if you persuade him? So sure, he came in and talked to him. He was having no side effects. No, he just said, look, I don't want to be on this injection forever. It's terrible. I have to go in each month, get the injection, such. I want to come off it. And I said, okay, that's all right. Let's just monitor things. So, it's absolutely his choice. We sort of explained the concerns and risk of relapse. His choice, he came off it. About a month after his injection was due, and he hadn't been on it, his self-care started to deteriorate. He wasn't doing so well. He and his dad came back in. We got the injection reinstated, and off he went. I haven't heard anything more from him since. But the issue here is we knew exactly what was happening with his medication. Back in the days when you use oral medication, the Martins just go off their medication and they relapse. And you think, why have they gotten sick? Are they using cannabis? Is the medication not working? What's happening? When you're on the long-acting injectables, you know exactly what is happening, so you can sort of control that variable. And so if you stop it and then people then get unwell, you know what's happened and you can sort of step in and such. How long should people stay on medication? The answer is we don't know. The simple answer is don't know. There was this review done whereby they looked at people who were randomized. These are patients who are well with either first episode schizophrenia or with either schizophrenia, first episode schizophrenia or first episode psychosis. And they're randomized either to continue medication or stopping medication. I'll just take you through first line. So John came back in 82, followed up patients for a year. Those who are maintained, none relapsed. Those who are randomized to placebo, 40% relapse. And you can see that sort of when you go down, the people who are randomized to placebo tend to do less well than those who are sort of randomized to continue medication. And we say, the guidelines say, keep people on medication for 2 years. And that's because most of the studies just go for 2 years. We actually don't know how long people need to stay on it for. There's been 2 trials I want to bring your attention to. One is the one by Vonderlink. People often quote this. And this was where people were initially, the initial trial where people were sort of randomized to treatment cessation versus maintenance. And it showed this benefit for sort of maintenance. And then they followed the people up 7 years later. Sorry. A lot of attrition, a lot of other problems. When they followed up, the two arms are pretty indistinguishable. A lot of problems with methodology of this trial, which I won't go into, but I don't think it's a good way to talk about it. Rob Nemsley, the study that was referred to, I actually reviewed this for schizophrenia research. What he showed after people who were well in remission, he randomized them either placebo or fish oil, thinking that fish oil might be protective. Up to 90% of his patients relapsed after they were sort of randomized off medications. 90% relapse rate, super high. So it gives an idea of sort of when you stop medication, the vast majority of people will relapse. And the issue then was sort of, I think it was highlighted this morning when I studied about it. This I think is one of the most important studies that in terms of clinical studies that have been done in my career. It was mentioned this morning, but I really want to highlight it. So the inclusion criteria of the study, that the aim of the study was to compare the treatment responses to antipsychotics in the first episode of psychosis to the second episode of psychosis. And to take you through the inclusion criteria, it was these. They were referred for the first episode of psychosis. They had to be included in the study, they had to be in remission following commencing antipsychotics. So they had to sort of be in remission. They then had to cease their antipsychotic, so they're non-adherent to antipsychotic, and then they had to then be put back on the same antipsychotic for the second time. So they're getting the same treatment. There's a dogma amongst psychiatrists, they responded previously to risperidone, let's use risperidone again, it should work and such. So they reintroduced the same antipsychotic treatment. And they collected 130 participants over 10 years, and the outcomes were measures of the of symptom rating scales between the first and second episode. And so what you see is that the blue line is the first episode. You see that as a group, you get a fast reduction in the symptoms and a greater reduction. The second episode, it takes longer for people to get well as a group, and they don't get as well. And the slide that was shown this morning, I think this is a really important slide. 50% of people who got well in their first episode, when they relapsed, did not get well in their second episode. Now think about that. That is really very, very important, really salient. And so what the speakers are talking about this morning, we've got to prevent relapse. 100% agree with that. We do have to. The thing is that clinicians, we're not good at explaining this to patients. We don't be really clear about this. So we can't tell people what to do. What we can do, though, is share this information so people are making really good, informed decisions. You'll always get people who choose not to follow medical advice. I had a friend a decade or so ago. She had breast cancer. She was a health professional. She chose to have natural medicines rather than following medical advice. She passed away. Her son doesn't have a mother. You'll always, in all areas of medicine, people will choose not to follow medical advice. That's okay. What's really important is that people have the information, so when they're making that choice, They know exactly what they're deciding. And this is what I think as clinicians, we need to get better at. So this is his final bit, is really providing information to families. We need to spend a lot more time with families. When we sort of see a consumer, psychosis is a life-changing diagnosis. It's not something where you can't just rush through and see the patient, see the consumer and think that it'll be okay. You've got to spend time. So one session explaining what's happening is not enough. You need to spend more time. You need to explain psychosis. I use diagrams. I have this on my desktop in my office, and I explain. And I think the diagram just helps them to understand, there's changes that are going on in the brain with this. There's dysregulation dopamine. There's too much dopaminergic activity in the Australian brain, and there's not enough in other areas of the brain. And what the medications do is they just normalize its dopamine activity and such. So I sort of let people know, and that gives them a chance to sort of ask questions about it. But I find the diagrams are really helpful and such. And then I explain the role of medications with them. And really importantly, I share the clinical uncertainties. I say to people, in those who have a full response to treatment with a schizophrenic under remission, and most of the people who I see do get that full response, and it's great to see, I explain that about 20%, you heard this from the speakers this morning, about 20% can stop their medication and stay well, but 80% can't. And we've got no way of knowing if your son is in the 20% that can or the 80% that can't. We just don't know. No one can tell you. And that's an uncertainty. That's uncertainty I have, is uncertainty that your cells all have. And I say, in those people who stop their medication and get unwell, the 80% who do get unwell again, half those won't get well next time. So you need to sort of really understand this information. I just find by giving them these figures and saying, look, let's not make a decision today. Can you please go away and think about it, come back next week and we can talk some more. And it really gives families this opportunity to sort of think it through. So I think that by sort of following the principles which have outlined this paper, everyone can practice excellent medication management of psychosis. Thanks very much.